Hi, this is Menace Joannides, Chief Medical Director at Optimum and today we're in the Optimum Academy, Pulmonary 101, video number 4, Understanding Asthma. So, what is asthma? It's a chronic respiratory condition characterized by inflammation and narrowing of the airways, leading to recurrent episodes of wheezing, coughing, chest tightness, and shortness of breath. So these symptoms can result from the increased sensitivity and reactivity of the airways to certain triggers. And key features of asthma include airway inflammation. The airways become inflamed, making them more sensitive to various environmental factors. Bronchoconstriction, the tiny slips of muscle surrounding the airways can tighten, narrowing the airway passages and making it more difficult for air to flow, and so the applicant or patient feels short of breath. And then increased mucus production. Globs of gooey mucus can plug up the airways, further contributing to airway obstruction. So it's harder to blow that air out. So asthma symptoms can vary in severity and frequency, with individuals experiencing intermittent or persistent symptoms depending on their particular disease. Common triggers include allergens like pollen, dust, mites, or pet dander, or respiratory infections. So even a viral infection can trigger an asthmatic attack. Exercise, exposure to cold air, and irritants like tobacco smoke or air pollution. Asthma is chronic, although applicants or patients who have asthma may just have episodic episodes of asthmatic problems, but it can be effectively managed with proper medical care in most cases. So, treatment typically involves the use of bronchodilators to relax the airway muscles and an anti-inflammatory medication to reduce the inflammation in the airways. The applicant or patient needs to work closely with healthcare professionals to develop a personalized asthma action plan that helps control the condition as an outpatient and avoid emergency room visits or hospitalization. So in asthma, an acute asthmatic attack can severely reduce the airflow in the bronchial tubes, and any pulmonary functions that are done during that episode may reflect that. But after the attack resolves, the pulmonary function test may improve significantly. So you may have one pulmonary function test that shows significant obstruction, and another one sometime later which shows that everything has improved. So PFTs, or pulmonary function tests, in the APS may show a wide fluctuation in forced expiratory volume in 1 second, and that's one of the key things that we watch for. How much air can the person blow out in 1 second when they're asked to blow out as fast and as much air as they can? So in airway obstruction, you can see two different looking bronchial tubes pictured here. One airway has a nice clear passage, so a lot of air can flow in and out through that breathing tube. However, to the right, it shows what happens in possibly an asthmatic attack, where there's narrowed airways with tightened muscles constricting the airway, inflammation of the wall, so the wall is thickened, and then there's additionally mucus inside of the breathing tube to block the flow of air. So much less air can flow through a person's breathing tubes when they have an asthmatic, any asthmatic symptoms or an asthma attack. In juveniles, especially young babies, the airways are tiny to start with, as the person hasn't developed yet. So when you start with a tiny airway and then you add any features which blocks the airflow, you can see what kind of problems you're going to end up with. So that's why babies, young kids can have an asthma attack, which kind of disturbs their breathing, and they may require rapid care in order to reestablish better breathing through their airways. So one of the key features I mentioned about pulmonary function test is the forced expiratory volume in 1 second, or the FEV1. And you can see to the left what the graph looks like. On the y-axis is the volume in liters of airflow that the person is able to exhale. And on the bottom, on the x-axis, so the left is the y-axis, the volume of air. On the bottom is the x-axis, the time in seconds. So the healthy person, you can see the black curve. When asked to blow out as much air as they can as fast as possible, they get almost all of their air out within 1 second. It's substantially the majority of their air they can get out very quickly. However, in the person with obstructive lung disease, which has asthma, which has the inability to get the air out fast, you can see that in 1 second, the person has a reduced outflow of air when asked to blow as much and as fast as possible. So that's why we call it obstructive lung disease, or in this case, asthma, where the person has an obstruction to getting that air out. And you can see to the bottom right the difference in the airway size and how much more air you could get through a normal bronchiole or bronchial tube than you could through one that has an asthmatic attack, where the muscles are tightened around the airway. There's inflammation and mucus in the airway. And when you think of this in terms of traffic, is there poor traffic flow because everything's clogged up, like on the expressway here in Chicago? Or is there good flow of the traffic? So much easier for the cars to pass when everything is clear. So asthma in juveniles is often described in APSs as reversible airway disease instead of asthma. So they may call it RAD, and that again is usually treatable with bronchodilators, which we're going to talk about. Many children have bronchospasm or closing up of their bronchial tubes and wheezing with a viral respiratory infection. And asthma attacks tend to become less severe as the child grows older, and their breathing tubes in general get to be larger, and they're less likely to be clogged up when they have an inflammation from an infection like a virus. And often treatment with a nebulizer or inhaled steroids or bronchodilators in an inhaler may be useful in juveniles just as they are in adults. Often a nebulizer is used because it's easier to administer the medication to the child in that fashion, and I'll show you why. So to determine what the status is of somebody's lung function, at home, people can use peak flow meters to get an idea of how their asthma may be on a particular day compared to others. And you can see these are normograms for how much air can be blown out at certain ages in men and women, and a small device as shown up at the right. And now there's all kinds of devices available, can be used to measure, what is the person's function on a particular day, if they're having symptoms or not having symptoms. And they can actually record these values and keep track. So any evidence of exposure to smoke in a person with asthma is going to be deleterious and a problem. So if the parents are smoking and the child has asthma symptoms, that's going to be an adverse environment for the child to live in, and they're much more likely to have asthma attacks. And the same goes for if they're exposed to things like marijuana smoke or any kind of smoke or environmental factors that might irritate their lungs. So an asthma anyone who has asthma should be hopefully in a clean air environment to reduce their likelihood of having another asthma attack. Now, the best way to deliver medicines to the lung, where the problem is to actually provide the medicine directly to the lung tissue. If you take a pill, it has to go through the entire body, be metabolized, and then a little bit of that drug goes everywhere, right? Arms, legs, abdomen, head, and where you want the medicine is in the lung. So that's why an inhaler is such an ideal way to deliver medicine to the lungs. And here's a picture that shows all different kinds of ways to deliver that medicine to the lung. You can see in the upper left, a young baby, they can't really control how they would inhale with an inhaler to get the medicine to the lung. So a nebulizer is used with a mask, and the baby can just breathe in and out, and the medicine will be delivered. It will be nebulized into the right size particle to be delivered to the lungs and provide bronchodilation. With a child that's older, as in the bottom left, in order to sequence the squirt of the inhaler with an inhalation, sometimes kids have trouble squirting and then breathing in. They tend to breathe out when they squirt or do something else. So what you can do is add a spacer. You just squirt the inhaler, the medication goes into the spacer, and then the child can breathe whenever they want, and the medication will be delivered to their lungs. So that's an easy way to do it. You can see to the right, the adult is just using a nebulizer. The medicine is put in that little cup, and this little device generates airflow to make little nebulizer particles that can go into the lung. And then I have a picture of those individual doses that can be put into the nebulizer. You just break off one of those little plastic doses, pop off the top there, and then just dump it into the nebulizer, and you're off and away on a treatment. So what kind of inhalers and medication is used? Beta-2 agonists, both short and long acting, are the frontline treatment for both asthma and COPD, and they exert their bronchodilatory effects on the airway, smooth muscle cells, anything that is an anti-inflammatory, like a steroid, can also be used as an inhaled medication to help decrease the inflammation. We no longer use beta-1 agonists because they have an effect on the heart, make the heart speed up. So particle size is important, just as we talked about in the COPD section. You want the size of the particles to be about 1 to 5 microns. If they're less than that, they may just suspend in the air and not be deposited in the bronchial tree. And the medications that are used are short-acting bronchodilators like Ventolin, which is more or less a rescue inhaler if you have an acute episode and you need something right away. But most people are prescribed a long-acting bronchodilator, which can be used once or twice a day on a regular basis. So every day they would be using this inhaler to prevent episodes. So hopefully they don't need their rescue inhaler. Steroids can also be delivered, and budesonide is a typical pulmonary steroid that's delivered in an inhaler to decrease inflammation. And then also anticholinergics can be used. And drug companies mix and match these combinations, and you see them advertised on TV. Some are supposedly only for COPD and not for asthma, but basically the same type medications are used for both diseases. Instructions on bronchodilators are tricky, and you have to read the instructions very carefully. There may be a instruction on how to use it the first time, and you may have to pump a few pumps into the air before you actually use it to inhale it. If it tips over or drops, you may have instructions on how to use it. You may have to be washing out the plastic piece in order to keep it clean. There's a lot of instructions, Often they're not explained to the patient when they get the prescription, and they may not be ever using it in the correct manner, even though they're paying an arm and a leg for these very expensive inhalers. This particular one is Symbicort, which is 2 drugs, a long-acting beta agonist, LABA, and a steroid. And the dose is 2 puffs twice a day on a regular basis in order to prevent future attacks. So in underwriting asthma, what are the important features? Pulmonary function tests may be done at the time of an asthma attack, so the FEV1 percentage may be low at that time. However, it may improve significantly after treatment with bronchodilators or steroids. So you have to kind of scan the APS and kind of take all these different things into consideration when you're looking at what kind of risk does this portend for the applicant who's applying for life insurance. When the PFTs are done when the applicant is doing well, they may be normal. So you have to adjust in your mind, what is the overall rating I should apply? ER visits or hospitalizations may be more worrisome because either the applicant is not using routine medications to prevent the disease, or the disease is so severe that even those kind of regular medications aren't preventing asthma attacks. And any time you see the word status asthmaticus, that's usually a life-threatening event where the applicant has such severe asthma that they can't break it with a treatment, and that definitely would be a high-risk feature. So that completes video number 4 of our Pulmonary 101 Optimum Academy series. Please tune in to the rest of our series in Pulmonary 101.